A very good evening and a grand welcome to all in this 10th session of Tuesday Takes brought to you by Maha IP and Women's Committee Maha IP. We are today celebrating Antibiotic Awareness Week with the theme of Antibiotics Protocol. So let us know from our all the faculties and our experts about the Antibiotics Protocol. Myself, Dr. Sonali Shirbhate, Chairperson, Women's Committee Maha IP, and my co-host, Dr. Nivedita Patil, Zonal Member of Women's Committee from Kolhapur. We will be hosting this session today. And once again, a grand welcome to our President, Dr. Ramakant Patil sir, Secretary, Dr. Amol Pawar sir, our guest of honor, Dr. Vasant Khalatkar sir, our judges, Dr. Pramod Kulkarni sir, and Dr. Tanu Singhal madam, our speakers are Dr. Daina Rahis, Dr. Shamal Jain, Dr. Dattatray Kulkarni, Dr. Rohan Bobde, Dr. Keyur Mahajan. They are all from the various, all four zones of the Maharashtra. I welcome all the Central IP dignitaries as well as Maha IP dignitaries in this platform, as well as I welcome all the delegates of this session. So let us move further towards the session. Most importantly, I would like to thank all my zonal EB members. Because of them, this session was earliest possible even in the Diwali. I would like to thank our co-chairperson, Dr. Neha Singh, our convener, Dr. Manjusha Serkar, our zonal member, Dr. Pallavi Patil, Dr. Mangai Sinha, Dr. Girvita Raikar, Dr. Shilpa Dudgaonkar, Dr. Nivedita Patil, Dr. Sonal Shinde, Dr. Manjusha Giri, Dr. Swati Patil, Dr. Sucheta Pofre, and Dr. Dipti Deshmukh. I would like to thank them all for this session. With these words, I would like to invite our President for his blessings and guidance for this session. Over to you, Dr. Ramakant Patil, sir.
Thank you, Sonali. Good evening to all. It is nice that we are back to business of academics from election fever. So I take this an opportunity to congratulate Dr. Vasant Khalatkar for being elected as President-elect 2025. Also, Dr. Atul Kulkarni as Vice President West Zone, Dr. Parmanand Andankar as a General Secretary, Joint Secretary Admin for 2 years, and all the EB members who got elected from Maharashtra, our Secretary General Dr. Amol, today's one of the judges Dr. Pramod Kulkarni sir, and Dr. Sanjeev Joshi, Dr. Vinayak Patki, Dr. Jitendra Gawane, Dr. Bela Verma, Dr. Renu Boralkar, and I will particularly like to congratulate this Women's Committee of Maha AP for successfully conducting all these Tuesday takes month after month successfully, and every time I really appreciate their efforts that every time the speakers they have chosen from different parts corners of Maharashtra, and they are taking extra efforts and going extra mile to get these their slides and their talk approved by the judges, and that will give a crisp and crystal clear message across the board to the delegates who are attending these webinars. And Dr. Sonali, Dr. Neha, Dr. Manjusha Sherkar, these all three leaders of Human Committee are being ably supported by Dr. Pallavi, Nivedita, Dr. Dipti, Dr. Manjusha Giri, Dr. Mangai Karsasina, Dr. Shilpa Dudwakar, Dr. Grevita, Dr. Swati, and Dr. Sonal Shinde. It is a really great pleasure that to attend this academic bonanza, and it is why I feel really privileged to work with this wonderful team of our Secretary General Dr. Amol, our Treasurer Dr. Mohan Warke, and all the team, and able support by CIP President and all the EB members for CIP from Maharashtra. And we could conduct so many programs, and nearly 6 programs per month we are conducting academic programs and non-academic programs. And this has been possible by Maha IIP EB members. And they are supporting. And I will like to congratulate the today's speakers, Dr. Shamal Jain, Dr. Dattatray Kulkarni, Dr. Keyur Mahajan, Daina Rahish, and Dr. Rohan Bobde to come forward and prepare their presentation on this Tuesday Take program for antibiotics. So with these words, I again wish all of them a best luck, and we are all ears to listen to them. And for the from expert comments from our judges, we have got the honor to listen to Dr. Tanu Singhal as a judge and Dr. Pramod Kulkarni sir, who is my senior EB colleague, and again a infectious disease specialist, and probably our president-elect 2025 has joined, and he has found time, because day by day his time is going to be very we will not get his time, but we will again welcome him and congratulate Dr. Vasant. When I said congratulations, you were not there, and we are really happy and proud for you. Over to you, Sonali.
Yes, thank you, sir, for your kind words. Now, really, we are very fortunate that we had got today a guest of honor from my own Vidarbha zone, and especially, sir is the president-elect for 2025. I would like to congratulate sir, and I welcome sir for his blessings to us for this session. But before that, I would like to say few words about sir. There is many more to say about sir, but in short, I would say about sir that he is President-elect CIAP 2025. He is consultant pediatrician and neonatologist from Nagpur. He is pediatric diploma in infectious disease. He is national chairperson for pediatric infectious disease chapter. He is national chairperson for neurology chapter of IIP. He was organizing chairperson for Pedicon 2018 Nagpur, and he was EB of Central IIP in 2009, 2014 and 15. And he has many publications and national awards for many of the IIP programs. Welcome, Dr. Vasant Khadkar, sir. Over to you, sir, for your kind blessings.
Unmute kar, Vasant.
Sir, unmute kara. Dr. Khadkar, sir, kindly unmute.
Done?
Yes.
Yes.
Loud and clear.
Good evening. Good evening. Greetings from Central IIP and Orange City, Nagpur. I really want to thank you, all the people, that you had made me to get this coveted post of Central IIP. That's a President-elect Central IIP, and my working will be in year 2025. But I think this year is a learning year for me, and I will try to justice this year definitely. See, this ID chapter is my hardcore chapter, definitely. And today's topic is definitely it's a touching part of my as a president-elect, president of ID chapter. So really, today there is a need of that antibiotic stewardship to say no to antibiotic, and all the stalwarts in ID chapter, they are trying hard for this to have a good antibiotic stewardship and to say the no to antibiotic and rational use of antibiotic. I wish all the best. I'm another on another Central IIP meeting, so I will not take much of your time. I wish all the best for this program, and I really love to attend this program. Thank you very much,
sir, for your kind words. Let me tell you one thing, that our all speakers, within the span of very short span from Diwali, they had prepared their presentation under the able guidance of President Dr. Ramakant Patil sir and Secretary Dr. Amol Pawar sir. So I would like to congratulate all the speakers that in a very short time they had prepared for this session. So congratulations to all. Now I would like to welcome our Secretary General Dr. Amol Pawar sir for his kind words about this session.
Thank you, Sonali ma'am.
And would like to congratulate him for the past IIP elections for his great win.
Thank you, Sonali ma'am, for your kind words. First of all, I welcome both the experts, Dr. Tanu Singhal ma'am and Dr. Pramod Kulkarni sir, for accepting the invite to be as an expert and to guide the incoming speakers who are from all over Maharashtra. And this Tuesday Techs was initially started last year under the chairmanship of Dr. Renu Boralkar ma'am and Sonali ma'am as a co-chairperson, and this has become a very good and very appreciable program all over India. And with this, many young speakers we have got for state pedicons or zonal pedicons also. So as already Dr. Makant Patil sir has envisaged all the details about this program, and newly elected EB members and President 2024, Dr. Vasant Khaladkar sir also. And I wish good luck to this program. Please continue the program. Thank you. Thank you, Sonali ma'am. Over to you.
Thank you, sir. The MMC observer for this session is Dr. Rajendra Kulkarni sir from Nashik. I would like to invite him for his kind words. Dr. Rajendra Kulkarni sir. Sir had not joined, I think. So, moving towards the session, let us know in a short about our judges, today's judges, and it will be followed by the start of session. Would like to say a few words about Dr. Pramod Kulkarni sir. Sir is MD, MRCPH and Diploma in Pediatric Infectious Disease. Sir is Consultant Pediatric Infectious Disease at KM Hospital, Dinanath Mangeshkar Hospital, Unique Hospital and SKN Medical College, Pune. Sir has various positions in Central IIP, EBS 22, 23, 24. And he was National Executive Board Member of Infectious Chapter in 19 and 2021. He had contributed to many books chapter on rational antibiotics in pediatrics, on pertussis surveillance and COVID registry. He is trainer for EPID, RTIJM, PG Education and Ultra Module of Central IIP. I would like to congratulate Dr. Pramod Kulkarni sir for his great win in the past EB elections. Welcome, sir. Then our second judge, so our second expert, Dr. Tanu Singhal madam. She is MD Pediatrics, MSc Infectious Disease and Tropical Medicine from London, UK. She is attached with Kokilaben Dhirubhai Ambani Hospital, Mumbai. She is expert member of Pediatric TB NTEP, board member and Fungal Infection and Study Forum. She has received many awards like Dr. I.C. Verma Excellence Award. Her areas of interest is COVID-19, tuberculosis, antibiotic resistance and vaccinology. She had many publications, about 101 in index journals, 3 books and 25 books chapters. Really very great, madam. Proud of you, ma'am, very much. And welcome, madam. So now, hand over to Dr. Nivedita Patil for our start of sessions.
Thank you, Sonali. Good evening. Am I audible?
Yeah,
Yes,
loud and
yes,
clear.
Yes.
Welcome all. Let us proceed to the scientific session. The theme of today's Tuesday Takes, as you all know, is a very important topic, that is antibiotics protocol. The first topic is antibiotics. What's rational use? What's empirical? I invite the speaker of this topic, Dr. Daina Rahish, who is consultant pediatrician at Bethany and Jupiter Hospital, Thane. Over to you, Daina.
Thank you, Dr. Nivedita ma'am, and thank you everybody. Thank you MAHA-AP and Women's Committee for giving me this wonderful opportunity and wonderful platform to talk on such an important topic. Is the screen visible? Am I audible? All okay?
Yes, madam. Kindly move forward. Okay,
so let's start on the important topic. The opening batsman, what's rational and what's empirical treatment concerning antibiotics. So when I was looking up the rational use, WHO had given one definition for rational use of antimicrobials, which said that patients receiving medicines appropriate to their clinical needs in doses that meet their own individual requirements for an adequate period of time and at the lowest cost to them and the community is what is called as the rational use of antimicrobials. So it's nicely put up in this hexagonal diagram, which says the rational use is right drug, right dose, right duration, right administration, and at the right cost. Now, there are certain factors. When there comes rational use, there comes irrational use. So why there is irrational use of antibiotics or any antimicrobials for that reason? So there are certain factors which were studied. Patient-parent factors were some and physician-provider factors were some. So if you see at the patient-parent factors, there were consumer demands, which we all see in the OPDs. There is a time-conscious society which says we want quick, that's what is the common concept that quicker treatment, antibiotics heal them quicker. Economic rationalism is some parents put up. There are a lot of misconceptions about what antimicrobials do, how they do. Fever respond to antibiotics. We have heard so many times things like आज हमने paracetamol नहीं दिया, antibiotic दे दिया fever के लिए. So those things are very commonly heard. So those are one of the few reasons why the parent reasons. Now there are certain physician or provider factors also, certain pressures, real or perceived pressures by doctors, technological advances or technological limitations also for that matter, where there are no reports or no culture reports coming. Self-economic concern again. Okay, litigation concerns are very upcoming nowadays. Physician fallibility, inadequate knowledge, cognitive dissonance. So these are certain factors for inappropriate use. Now, when the inappropriate use of antibiotic comes, we land up in this antibiotic paradigm, where excessive or inappropriate antibiotic use leads to antibiotic resistance. That leads to failure of antibiotic treatment, and ultimately we end up in this vicious loop, which is difficult to break and come out sometimes. So empirical versus rational use of antibiotics. Empiric use is definitely beneficial, and it helps us reduce in mortality rate for the child. But on the same and in the same context, if there is an irrational antibiotic prescription, or if the antibiotics are not used in proper combinations, or if there are no corrections for the renal adjustment doses, or if it's irrationally used, they will ultimately end up in poor clinical outcomes, mortality of the child also. So empiric use is very double-edged sword, which should not be ideally used. Rational use, on the other hand, definitely reduces the rampant antibiotic consumption use, and using it rationally also helps us in saving this important drug for genuine reasons. So there was one very important article which I would like to thank here Dr. Pramod Kulkarni sir for sharing this article with me, written by Tanu ma'am only, which was Rationalization of Empiric Antibiotic Therapy. It's a very nice article, ma'am, written in, it was published in Indian Journal of Pediatrics. So infectious. I just went through that. That was telling us how we can rationalize the empiric use of antibiotics, and is empiric use actually needed? Do we really need to use it empirically? So inappropriate use of antibiotics again encompasses two things: either you are misusing the drug or you are abusing the drug. So misuse of drug happens when there are multiple drugs which are used, maybe unindicated most of the times. If there is an inappropriate choice made, if it's used in inappropriate conditions for inappropriate diagnosis, basically, the duration is equally important. If you give it for lesser durations, it really is as good as using wrong drugs. Irrational combinations, again, is a very important thing to consider. Abuse of drugs becomes, antibiotics becomes when you use it for certain conditions where it is not to be used, which are self-limiting rather. Also, most of the times as pediatricians, we see majority of our illnesses like upper respiratory infections are all they're generally viral infections. We should not forget the other protozoal infections, GI infections, for example. So antibiotics really are not the drug for every condition. So these non-bacterial conditions should be considered. Then certain non-infectious conditions, of course, autoimmune, rheumatological, these are all upcoming things. So these things also have to be considered rather than just hitting with antibiotics blindly. So if we just keep misusing or if this keeps happening, inappropriate use of antibiotics, as the picture shows, the microorganisms are all ready to climb up and sit up on our antibiotics. So how do we go about clinically? How do we go about the use of antibiotics becomes our question. So first question to be answered by us is, does the patient really need an antibiotic? Is it a bacterial infection? Does it look like a viral infection, which we need to analyze first before prescribing the antibiotic? If at all we feel that yes, there is a need, then what is the site of infection and what is your probable organism? Like one of my madams, my teachers always used to tell me, none of the reports have to come as a surprise. If you're sending some investigation, you should anticipate the report, what you're expecting. So you should have a probable organism in mind before you hit it with an antibiotic, or before you send the cultures also. And also, so having said that, you should send appropriate cultures. So you expect what organism to come from that. Choose appropriate antibiotic. Then, according to your suspected organism, maybe you can start a proper antibiotic. Where you need to escalate the antibiotics, where you need to use higher antibiotics. Nowadays, a lot of resistant organisms are we are seeing, including carbapenem resistant organisms. So when we go to such higher medicines are needed, higher antibiotics are needed, I think it is right to timely involve the infectious disease consultants. We have help all over. We have timely help from our state. I think they should be involved rather than using these rather than using these high antibiotics at our level. And of course, as we escalate, we need to know when to de-escalate the antibiotics also, any of these drugs for this matter, clinically and according to the reports. So the same thing put in a graphical pictorial manner, antibiotic, whether you use it or no, you don't use it when there is a viral infections, when there are self-limited or non-serious or slowly progressive bacterial infections. If you have to use it, you need to know which bacterial, what are you suspecting. When you need to know which antibiotic you have to use, you look at the pathogens, what could be the possible organism. You look at the drug efficacy, drug spectrum, whether you need a cidal or a static drug. Look at the other host factors, which are age, immunity, immunization status of the child, disease condition, exactly what is it, the site, severity, and progression of the disease. And when you have to use it, how do you have to use it? When you reach to that question, the pharmacokinetics and pharmacodynamics of the drug will help you decide on the route of the drug, the dose of the drug, the duration, the frequency, and how do you monitor the effects and the side effects of the drug. Also, during the drug period, what other parameters you have to monitor. So this is what you have to follow when you have to use the drug. And this is the basic ABCs of antibiotics. So as we have already discussed, we have to ask whether the antibiotic is needed. Second thing, B stands for bacteria, where we have to keep reminding ourselves that the antibiotics work against specific bacteria. And the most important thing, as important as starting the drug, is to stop the drug. So you should know when to stop the drug, how many days after, what is the duration of the need for the drug to be given. So after these basic things, I would just like to mention a few things. Dr. Shamal, the next speaker, will be my colleague, will be talking about specifically about what infections, what antibiotics, but we'll just talk about certain upper respiratory, commonly seen, just a brief thing about commonly encountered upper respiratory infections in our OPDs. Most commonly, what we see in children is common colds, these upper respiratory rhinitis. So they are, majority of them are viral infections. We might need to spend 10 minutes extra in the OPD in counseling them if they don't need an antibiotic.
Madam, your time's up. Is more than 8 minutes. Kindly wind up.
Okay. So just a brief view of upper respiratory, where acute otitis media and sinusitis is where we might really need antibiotics. And certain other common infections, which I would just like to mention, is urinary tract infections, enteric fevers, skin and soft tissue infections, and lower respiratory tract infections. Details of these will be covered by Dr. Shamal in the next talk. So I think short of time, we'll cut it off. Thank you so much for giving me this opportunity. Thank you, everyone.
Thank you, Dinah. That was a very crisp presentation. I agree that 8 minutes is a short period for such a vast topic. May I request our expert judge, Dr. Pramod Kulkarni sir, to give his expert comments.
Good evening, everybody. And Dinah presented it so nicely. The basic concepts of antimicrobial stewardship or rational antimicrobial use, to be very precise in practice. And she has given the basic concepts of empiric as well as definitive therapy. Just to elaborate on that, empiric therapy was a compulsion up till now, which is in you know that there is infection, but you don't know what is the pathogen, and you still have to go ahead with the treatment. That is the empiric use. But as we have heard from Diana, we have to take help of our microbiology laboratory to help us in getting the precise etiology and then modulate our antimicrobial therapy in this era. So empiricism was the previous era, and I will request everybody of you to go through the article by my honorable co-judge, Dr. Tanu ma'am. That IJP article is just fantastic. How to blend both the things, empiric therapy as well as rationality. Please go through that. And very well presented, Diana. Thank you so much.
Thank you, sir.
Thank you, sir, for your expert comments. We'll move on to next presentation. The topic is antibiotic stewardship in various infections. I invite Dr. Shamal Jain, consultant pediatrician at Jain Hospital, Nandurbar, to deliver her presentation.
Good evening, everybody. Thank you so much, Maha AP, Dr. Pramod Kulkarni sir, Ramakant Patel sir, and Tanu Singhal madam for giving me opportunity to present on this burning topic. Am I audible?
Yes.
I audible?
Yes, you are audible.
What is antibiotic stewardship? Actually, stewardship is the effort to measure and improve how antibiotics are prescribed by clinicians and used by the people. As resistance is increasing, the emergence of bacteria with multiple antibiotic resistance is a very important, is very concern. So prescribing antibiotics when they are truly needed, appropriate antibiotics with adequate doses, and using shortest duration of antibiotics based on evidences and along with narrow spectrum of antibiotics. When we are selecting our antibiotic, we should see first most common organism causing disease. Site of infection is important as some antibiotics achieve different concentration at blood at different site. For example, aminoglycoside achieve very less concentration at CSF, so they should not be used in alone at in case of meningitis. Age of patient is important because different age have different ages they have different organism involved. Drug pharmacokinetics and dynamics depends upon age. Immune status of patient, then immunization history is also very important. Information of use of antibiotics in recent past is also very important because that can lead to that will give information of about any resistant organism. Culture reports, we can change antibiotics according to culture reports. Then mechanism of action of antibiotics. We should always try to before starting an antibiotic, we should always try to attempt a bacteriological diagnosis whenever possible. For example, in case of UTI, we can do some simple urine routine microscopy. We should do blood culture for typhoid, and there are many circumstantial evidence of bacterial infection, and we can differentiate from bacterial and viral by examining patient. In viral infection, the fever at the onset is very high. It comes rhythmically every 4 to 6 hourly. In between fever, child is normal, and in viral infection, patient feels better in almost 3 to 4 days. There will be a contact history, and the extent of disease will be generalized in the form of abdominal, non-specific, non-localized, like abdominal pain, vomiting, rhinorrhea, body ache, like this. But in some cases, for example, infant less than 3 months and any degree of fever in neonates, premature infants, sickle cell anemia, in immunosuppression cases, nephrotic syndrome cases, splenectomy cases, we should not delay starting of antibiotics. We'll start some common infections in OPD practice. Common cold, which is mostly viral, we should not use antibiotics. Pharyngitis. Pharyngitis can be nasopharyngitis and tonsillopharyngitis. Nasopharyngitis is mostly viral, rhino, respiratory syncytial virus, influenza, corona, adeno. In adenoviruses, we can get symptoms of conjunctivitis along with the pharyngitis, which is pharyngoconjunctival fever. In case of enteroviruses, there are multiple ulcers in pharynx, multiple patchy ulcers in the pharynx along with fever, with severe throat pain. In bacterial pharyngitis, we will get pus at the tonsil along with tender submandibular lymph nodes and fever. Toxic child will be toxic. In these cases, when we suspect streptococcal pharyngitis, we should use amoxicillin, which is amoxicillin in 40 to 50 mg per kg per day for 10 days to prevent development of rheumatic fever. Children with penicillin allergy, we can use macrolides and first generation cephalosporins. Sinusitis, in sinusitis, most of the sinusitis cases also have a viral causes, but the child who is having rhinorrhea for more than 10 days duration, high fever more than 40 degree fever, we can use antibiotics, amoxiclav. In foreign countries, there is a resistance to streptococcal pharyngitis. They use in a higher doses 90 mg per kg per day. And other drugs are cefuroxime, cefdinir, IV. In toxic patients, we can use IV ceftriaxone or cefotaxime. Acute otitis media, these are also caused by same etiology. Antibiotics are indicated only in less than 2 years of age with severe and in others who is having severe disease. Same amoxiclav, and amoxiclav is a drug of choice with a higher doses of 90 mg per kg per day. UTI is main. There is a dictum that the infection above diaphragm should be treated with amoxicillins, and below diaphragm we should use cefixime. It's in general dictum. And in UTI, most of the cases of UTI are caused by gram-negative organism like Klebsiella proteus, uropathogenic E. coli. And in patients with the structural anomalies and in patients with indwelling catheters, there are chances of staphylococcal infection. According to this, oral cefixime and cefixime cefuroxime can be used in patient having high grade fever or less than 3 months of age. We can use third generation cephalosporin and aminoglycoside for 7 to 14 days. And according to culture report, drugs can be changed. The treatment should be done to prevent renal damage. Then infective diarrhea and cholera. Diarrhea is most commonly caused by 40%, almost 40 to 70% is by rotavirus, adenovirus, and enterovirus, in which rehydration therapy is important. No antibiotic should be prescribed. In cases where child present with dysentery-like symptoms like abdominal pain, vomiting, fever, along with mucus and blood in the stool, we can use ampicillin, cefixime, cotrimoxazole. Quinolone also can be prescribed. In cholera, along with the rehydration therapy, single dose of azithromycin 20 mg per kg per day or cotrimoxazole 10 mg per kg per day for 5 days can be used. Doxycycline 2 to 3 mg per kg per day also can be used. Skin and soft tissue infection, furuncles, impetigo, ecthyma is mostly caused by staphylococci and group A beta hemolytic streptococci. Oral cefadroxil is a very good choice. Amoxiclav, macrolide antibiotics can also be used. To prevent recurrence, we can use topical mupirocin and fusidic acid at carrier site for almost 3 to 6 months. Bone and joint infection and septic arthritis. In neonates, this bone and joint infection and septic arthritis is caused by gram-negative bacilli by hematogenous spread. And Staph aureus in cases where trauma and puncture site is there. Third generation cephalosporin have a good activity against gram-negative bacilli along with cloxacillin, and if we are suspecting MRSA, we can use vancomycin. The antibiotics should be continued for at least 3 to 4 weeks and in infants less than 3 months, the antibiotic should be given in a IV route, as they have erratic oral absorption. So the antibiotic should be given for 3 to 4 weeks. In pneumonia, in community acquired pneumonia, the organisms differs according to ages, but most common organisms are Streptococcus pneumoniae. H influenza cases are declining because of immunization. And
Your time's up, Dr. Shamal.
okay, ma'am, just one or two slides. Antibiotics are not indicated in common cold, sinusitis, croup tracheitis, also viral hepatitis. In dengue cases also we should not use antibiotics, and most of the exanthematous fever we should not use. So antibiotics should be handled with care. Okay. Thank you, ma'am.
Thank you, Dr. Shamal. That was very informative presentation. May I request Dr. Pramod Kulkarni sir to give his expert comments.
Well presented, Shamal, and that was a good overview of common pediatric infections and how to apply the principle of stewardship to our common OPD as well as up to level 2 care practice. Few things to be elaborated here about the risk factors. The things are evolving a lot. Characterization of risk factors becomes equally important. So just young age, less than 3 months, cannot become an indication for antibiotic. You know, the bacteremic illnesses with the common and universal practice of immunization against pneumococci and H. influenzae, the primary bacteremic illnesses are going very, very, very down, and to the tune of less than 2 to 3%. So even in a young child, a fever who is properly immunized, unless you have microbiological evidence or the child is too sick, one should not go for the risk factor of age, one should not go for empiric antibiotic therapy. So again, now we are maturing how to characterize individual risk factors and further narrow down genuine indications of antimicrobial therapy in that. Similarly, stool examination, 5 pus cells per HPF is not at all an indication. Visible blood in stool is still remains the indication, empiric indication for antimicrobial therapy. All other common conditions very well covered. Shamal, that was a nice presentation. Thank you.
Thank you, sir.
Thank you, sir, for enlightening us on the topic more. Let us proceed to the next.
Kindly unmute.
Nivedita, unmute.
Kindly unmute.
Nivedita, unmute.
Unmute.
Yes, sorry. So let us proceed to the next topic, that is protocols of antibiotics in NICU, the area where antibiotics are used at a larger scale and for a very long time. So I think this is a very important topic. I invite Dr. Dattatray Kulkarni, consultant neonatologist, Vithai Super Speciality Hospital, Latur.
Am I audible?
Yes.
At the beginning, I would like to thank MahaIP, Dr. Ramakant sir, Amol sir, and Women Wing, and Dr. Dipti Deshmukh ma'am to giving me this opportunity. I would start my presentation. So, objective of my talk will be to create an antibiotic protocol in NICU by doing the right, knowing the right indication to start an antibiotic. To know the right empirical antibiotic, and if you are dealing with culture positive sepsis, choosing a right antibiotic, then giving the antibiotic with a right dose for right duration, and writing the good prescriptions. So with keeping a right approach in mind. So moving further, if the baby is premature but there is no preterm PROM, if there is asphyxia, if there is a meconium aspiration syndrome, if there is a severe jaundice, the baby is admitted for clean surgeries, they may not need antibiotic. On the contrary, if the baby is symptomatic, they had to start on antibiotic without delay. Symptomatology of neonatal sepsis is varied to a great extent. So there can't be a one particular symptom suggesting sepsis. If the babies are asymptomatic, but they are having leaking PV or preterm PROM, there are risk factors present, then we should start with the antibiotic. So before starting any antibiotic, we should have a clear idea what the organism we are targeting, whether they are gram negative, gram positive, whether they are anaerobes. Based on that, we should start an antibiotic. So to decide about first line, second line, third line in a NICU, I would do landmark studies. One is a study, Danish study from Delhi, 3 big NICU, almost 13,000 babies with 14% sepsis rate positive. Two-thirds were having early onset neonatal sepsis and two-thirds were having gram negative growth. An interesting finding is both early onset and late onset sepsis have similar organism. That is from Lancet. Another study from JAMA involving 10 Asian countries, 48 studies, almost 8,500 cultures, 3 antibiotic regimen tested. And surprising finding is meropenem success rate is 65%. So bottom line is different organisms grows in different NICU, and antibiotic work, antibiotic success is to a different level. So to know first line, second line, third line in your NICU, you should sit down, do surveillance, then know what organism growing in NICU and what antibiotics are working in your NICU. So based on that, you should decide your first line, second line, third line. By and large definition, at least 70% organisms are covered. That would be first line. And stepping the ladder up, third line should be more than 90%. So once you started presumably right antibiotic, you should not upgrade antibiotic within 2 days, and you have to keep the supportive care optimum, and the switch from first line to second line to third line has to be based on culture and has to be assessed sickness by senior one. You can downgrade the antibiotic with confidence if there is a 2 sepsis screen at least 24 hours are negative, if the clinical improvement is there, or you know the precisely where is the infection. Like if meningitis, you go with alone with cephalosporin. That would be a best CSF coverage. So once you are in a safe boat, like if there is a culture positive, you should go with an antibiotic which is a tissue specific, organ specific. Like if I had a antibiotic choices available among the sensitivity, I will go with narrow spectrum. If I had ampicillin versus meropenem, I will go with ampicillin. If I had a cloxacillin versus vancomycin, I will go with cloxacillin. If there is an intermediate result, I will combine these two and combine 2 antibiotic available. If I am using for UTI, say, and using aminoglycoside, I will use it less than 1 week. So once you know you are starting right antibiotic for right indication, then you have to decide right doses. There are good resources available like IAP drug formulary, NNF Shishu app. These are handy mobile apps. Then there is a NeoFax. Then there is a neonatal AI app in this AI world presently developed by neonatologists from Hyderabad. This is quite handy. Even there are textbook available like drug dose handling. So by and large, the drug doses are based on the weight, 3 weight regimens, and what is the postnatal age, less than 1 week or more than 1 week. So to understand it, we should know a little bit about pharmacokinetics and pharmacodynamics. So peak level will decide the toxicity, trough level will decide the minimum effective concentration. So for best antibiotic success, the ratio of peak to trough level will be very much important. So for why aminoglycoside given every 24 hourly, why other are given 8 hourly, you should understand little about pharmacokinetic and pharmacodynamic. So once you know you are chosen a right dose, then you have to decide right duration. So first you should be very clear what scenario you are dealing. Only sepsis screen is positive, 2 days antibiotic enough. If there is a sepsis screen negative but clinical sepsis, 5 days antibiotic enough. If both are positive, at least 7 days. If you are dealing with culture positive sepsis but there is no meningitis, 10 to 14 days. If there is a meningitis, you have to go for 3 weeks. If there is a cons grown, the range can be 1 week based on whether bacteremia or meningitis. If there is a deeper infection like meningitis or ventriculitis or osteomyelitis, it can go up to 6 weeks. So once we decided right antibiotic, right dose for right duration and right indication, you should order a prescription which has to be from a limited list of 4 5 antibiotics, and every change of the antibiotic has to be under control of senior most or head of department or interdepartmental faculty like microbiologist or infectious disease specialist. So in a unit, you have to develop a culture of sending culture whenever there is a change of antibiotic or whenever there is a switch from first line to second line or third line. So moving further, if you are asymptomatic unit, in the Western world, there are different disease systems are available. NICE guideline, European guideline, they with a calculation they predict this is going to have sepsis, but these are not applicable in Indian setting because their predominant microorganism cons and cheese. Our Indian setting, it may not be applicable. So what we have to do, we have to do a sepsis screen. If they are negative for at least 24 hours apart, you can safely stop antibiotic. Otherwise, what approach we have discussed till the time, you can go ahead. If you are dealing with a neonate with symptoms and there is a suspect sepsis, every effort has to made to get to know what is the site of infection, to get the cultures done, and if their facility is not there, then at least the rapid diagnostic test for sepsis. And based on the clinical scenario, right clinical scenario, you have to decide the duration of antibiotic. So for any antibiotic protocol in NICU to make it success, the two extremely vital processes are important. One is audit of not only cultures showing what organism grown in early and late and drug sensitivity or antibiotic sensitivity. Apart from that, audit of processes which prevent neonatal sepsis like hand hygiene, IV cannulation, use of disinfectant has to be taken into consideration. And you have to check a trend like DOTS, days of therapy, antibiotic usage rate. Suppose compared to previous month, now antibiotic use rate is increased. Then you have to sit down and see where we are doing wrong in these 5 steps what we discussed. So like last World Cup final we lost, but what the Australian captain says that we have kept something reserved at the end, or if we have kept something best at the end. So even a best team is defeated with a right approach. So right attitude of antibiotic stewardship with keeping all these things, we can make antibiotic protocol works to the best potential in ANIC. Thank you.
Thank you, Dr. Kulkarni. You could highlight all the key points in a very short time. Probably that reflects your practical experience in the NICU. Thank you. I request our judge, Dr. Pramod Kulkarni, to give his expert comments.
Thank you, Dr. Dattatreya, for such an excellent presentation. It was absolutely reflective of your authority, hard work you have taken, clarity of your concepts, very well explained. I especially appreciate the two angles which you highlighted. One is the importance of the local antibiogram, which you emphasized on, and the second one about the audit part and surveillance part of it. That was just fantastic. I hardly have any addition to do that. Very nice presentation. Thank you so much.
Thank you.
Thank you, sir. We will proceed to the next topic. May I call upon Dr. Rohan Bobde, pediatric intensivist, Parijat Hospital, Amravati, to give his presentation on antibiotics protocol in PICU. Over to you, Dr. Rohan.
Thank you, ma'am. Am I audible?
Yes, yes.
Yes.
Yeah. Thank you for this opportunity to be on a state level stage. I'll be presenting our antibiotics protocol in PICU. The speakers before me has presented most of the part. So why a protocol is needed in a PICU? Because maximum patients, the antibiotics is the most common drug used in PICU. More than 80% children receives it. So a PICU protocol for empirical antibiotics will guarantee an adequate treatment. It will help to avoid toxicity and avoid occurrence of antibiotic resistance on a patient as well as on a hospital and population level. You can make your own protocol based on what flora you have in your community and in your ICU. You usually start with the broad spectrum drugs, and the aim is to narrow the spectrum as early as possible based on the cultures grown. So we will look system wise what infections are more common and what antibiotics should be used in these infections. So in CNS infections, when meningitis is suspected, the likely organisms there are Streptococcus pneumoniae, Neisseria meningitis, Mycoplasma pneumoniae. So here we go with third generation cephalosporin, ceftriaxone plus vancomycin. Vancomycin is usually added for the possible penicillin resistance pneumococci. If there is suspected shunt infection, there is post neurosurgery case or CSF leak is present. So the likely organism in such cases are all the above plus Staph epidermidis, Staph aureus, gram-negative coliform, including Pseudomonas aeruginosa. So in that case, we go for vancomycin and meropenem. Encephalitis are most commonly caused by viruses like herpes simplex virus, enterovirus, arbovirus, or mycoplasma pneumoniae. So for that, we start acyclovir and azithromycin we add for mycoplasma infections. If rickettsial infections are suspected, we go for doxycycline. The alternatives to doxycycline is clarithromycin and azithromycin. In respiratory system, if we are, it's very common to have severe pneumonia in our PICUs. So likely organisms in these scenarios are viruses. Then other organisms include Streptococcus pneumoniae, H. influenza, group A, Streptococci, gram-negative organisms, and atypical organisms. So here also the initial antibiotics that we go for is ceftriaxone and fluclox. And if you are suspecting an viral infection, so as oseltamivir can be considered with azithromycin according to your suspicion. If you are suspecting a MRSA, we go for vancomycin instead of flucloxacillin. Nosocomial and VAP are usually caused by Pseudomonas aeruginosa and other gram-negative organisms and Staph aureus. So here, the first choice of antibiotics will be depending on what flora is growing in your PICU. So we usually go for Viptas, meropenem, and vancomycin can be considered if staph is a predominant nosocomial infection in your PICU. We usually don't add vancomycin as our setup staph is rarely has never grown. In intra-abdominal infections, the likely organisms are group A and group B streptococci, E. coli, other gram-negative coliforms, L. monocytogenes, H. influenza species, Streptococcus pneumoniae, N. meningitis, Staphylococcus aureus, and gram-negative organisms. So here also, you have two options. We either go for the combination of ceftriaxone, metronidazole, and gentamicin, or piptaz alone will also do in some cases. So for the likely organisms in community-acquired sepsis, we have Streptococcus pneumoniae, N. meningitis, Staphylococcus aureus, group A strepto, and gram-negative organisms. So our initial antibiotic of choice is ceftriaxone plus amikacin, and if you are suspecting staph, then we add fluclox. We can either go for piptaz, meropenem plus vancomycin if the child is having septic shock, as the principle in PSU in such cases is hit fast and hit hard. For nosocomial infection, the organisms are same with addition of Pseudomonas aeruginosa and Staph epidermidis. So here again, based on our PSU flora, what flora we are going, if there are ESBLs, we go for higher antibiotics. So we can either start with piptaz, meropenem, or even carbamazepine resistant organisms are there. So we start with colistin. And if staph is also grown in our PSU, so we can add vancomycin also. In neutropenic patients, the likely organisms that usually infect the children are the above organisms plus Enterococcus species and Pseudomonas aeruginosa. So here also, the initial antibiotics is piptaz plus amikacin if there is a systemic compromise. And vancomycin can be added if you are suspecting a line, if there is a line and you are suspecting a line infection. Thank you. That's all from us.
Thank you, Dr. Rohan. That was very informative presentation. May I invite Dr. Tanu Singhal ma'am to enlighten us further on this topic.
Thank you, Dr. Rohan, for that nice and crisp presentation. So I would just a couple of comments from my side that, you have two types of patients admitted in your intensive care unit. One, those have severe community acquired infections. There, the choices of antibiotics are quite different. And also those patients who have been in the PICU for some time and then they get an infection. So you have to mentally try and distinguish between those two things so that you don't use the correct antibiotics. The second point I wanted to make here is that, source control is very important in the PICU apart from your antibiotic prescription. And third is that, we should, because in the PICU, we tend to use very, high level antibiotics, which are costly, which are having adverse effects. You can really now try and come down on the duration of therapy. Because it's not like, earlier we used to say that every infection you need to treat for 10 to 14 days. That's not true. Many gram-negative infections, etc., you can treat for 7 days and that would be enough. You need to treat for 2 weeks only in Staph aureus and Candida. So you can exercise stewardship in that way. And fourth and last point is that you must make efforts to de-escalate in the PICU. So as you said that in PICU, you correctly said that you start heavy broad spectrum antibiotics, but then once 48 to 72 hours later, your cultures are back and you see the patient and then try and take off, because the biggest fear people have is that why rock the boat? You have started meropenem and you find your isolate is sensitive to ceftriaxone. You don't want to come down, but you should, because otherwise you will lose future options. So I think that is what I wanted to say. Thank you.
Thank you, Dr. Tanu Singhal. That were very valuable points that you shared with us. Let us now move on to the next session. I invite Dr. Keyur Mahajan, who is an infectious disease consultant at Mai Mangeshkar Hospital, Pune. Over to you, Dr. Keyur.
Am I audible?
Yes.
Yes, yes.
And the slides are visible?
Yes. So you have to make it full screen.
Yeah, sure. Okay. Thank you, Maharashtra IB, for inviting me to be part of this lecture series. I know I'm the last person, so I will be quick and I will be finishing in time. We are discussing what antibiotics to be used, in which scenario, at what scenario, in ICU, PICU. But now we are discussing whether antibiotic we are using will be useful or not, because we are in the era of antimicrobial resistance. So we have made our small little tiny bacteria into Hulk by feeding with antibiotics. Now, this is the theme of this year's World Antimicrobial Awareness Week, preventing antimicrobial resistance together. So, yes.
Sir, your slides are not moving. Kindly reshare again.
Okay.
Till that, Dr. Rajendra Kulkarni, our MMC observer, is present in this session. I would like to invite Dr. Rajendra Kulkarni, sir, for his few words. Dr. Rajendra Kulkarni, sir.
Yes. Hello.
Hi,
Am
yes,
I audible
sir.
now?
Yes,
Yeah. I think. Hello.
Yes, sir.
Yes, Rajendra. Please
Yes.
go ahead.
Nothing. Yeah. I congratulate my IP and for this good project. They are continuously having this webinars on very important topics, and they are bringing out the rising stars of IIP academicians. That is a wonderful thing they are doing. I congratulate my IIP President and Secretary Dr. R.D. Patil and Dr. Amol Par for that. Let me take this opportunity to congratulate all the newly elected EB members of Maharashtra who are present here, and I wish all the best for their tenure, and I wish success for this webinar. I don't take much of your time, and I allow you all to please carry on the academic session further. Thank you.
Thank you, sir. Over to you, Dr. Keyur.
Are the slides visible now?
Yes, visible full screen. Yes.
Thank you. So, WHO has declared that antimicrobial resistance is one of the top 10 global public health threats facing humanity. So, misuse and overuse of antimicrobials are the main drivers in the development of drug-resistant pathogens. Lack of clean water and sanitation and inadequate infection prevention and lack control promotes the spread of microbes, some of which can be resistant to antimicrobial treatment. The cost of antimicrobial resistance to the economy is significant. In addition to death and disability, prolonged illness results in longer hospital stay, the need for more expensive medicines, and financial challenges for those impacted. So without effective antimicrobials, the success of modern medicine in treating infections, including during major surgery and cancer chemotherapy, would be at increased risk. So we need to preserve our antimicrobials. This is a picture of Sir Alexander Fleming. He is the discoverer of penicillin, the first antibiotic, and he got the Nobel Prize in 1945. During the Nobel Prize lecture, he said, "The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin-resistant organism." When he invented penicillin, he had in mind that if not used properly, the organisms are going to develop resistance and the drug will be useless. So these following charts I have cropped out from the CDC website. They have shown that from the discovery of penicillin since 90 years, how antibiotics have developed resistance. We can see here, the penicillin was released in 1941, and as soon as 1942, it started showing resistance in Staphylococcus aureus. Again in 1967 and 1976 for Streptococcus pneumoniae and Neisseria gonorrhea. The vancomycin was introduced in 1958, and we can see that by the end of 1988 and 2002, we had this Enterococcus faecium and Staphylococcus aureus showing vancomycin's resistance. Amphotericin B was released in 1959. By the end of 2016, we had Candida, which was amphotericin B resistance. Methicillin again in 1960, and same year, it showed resistance to Staphylococcus aureus. Same with extended spectrum cephalosporin. Cefotaxime was introduced in 1980, and by the end of 1983, the ESBL started. The E. coli started showing extended spectrum beta-lactamase resistance. Azithromycin was introduced 1980. By the end of 2011, we had azithromycin resistance in gonorrhea. Similarly, with higher antibiotics also, imipenem, ciprofloxacin, even fluconazole, antifungals. We can see the 1990 FDA approved the use of fluconazole, but when the use was approved, it was already showing some Candida species resistance. Capsofungin was approved in 2001, and by the end of 2004, it showed resistance. Even the ceftazidime avibactam, which is the highest antibiotic used in gram-negative sepsis, it is showing resistance to the Klebsiella pneumoniae. So WHO has categorized the organisms as a priority 1, priority 2, and priority 3 to differentiate the organisms on which we need to work fast to develop more and more antibiotics, or more research has to be done. The 3 bacteria they have shown as they have priorities as a critical are Acinetobacter baumannii, which is carbapenem resistant, Pseudomonas aeruginosa, which is carbapenem resistant, and Enterobacter shi, carbapenem resistant ESBL producing. So WHO has said that these 3 bacteria are in a very critical zone. In high priority, there are Enterococcus faecium, Staphylococcus aureus, H. pylori, Campylobacter, Salmonella, and N. gonorrhoeae. So these are the bacteria as they come into priority 2, high priority level, which needs more and more research to develop newer antibiotics to tackle these organisms. And the priority 3 bacteria are Streptococcus pneumoniae, H. influenzae, and Shigella. this list do not include tuberculosis, because the tuberculosis whose resistance to traditional treatment has been growing in recent year, but there are different dedicated programs for tuberculosis. So the WHO is not included in that list, but definitely WHO is saying that tuberculosis is having much and more resistance to different traditional treatments which we are seeing. WHO has estimated that in 2018, there were about 500,000 new cases of rifampicin-resistant tuberculosis identified globally, of which the vast majority have multi-drug resistance. Other bacteria that were not included, such as Streptococcus A, B, and Chlamydia, have low level of resistance to existing treatments and do not currently pose a significant public health threat. So, what is the scenario in South Asia? Lancet had carried out a global study in 2019, published in 2019, for discussing different types of bacteria which are showing multi-drug resistant, and they found that these are the 6 major bacteria: Acinetobacter baumannii, E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, Staphylococcus aureus, Streptococcus pneumoniae. These are the 6 major bacteria which are causing the antimicrobial resistance related mortality or morbidity in most of the population in South Asia. The analysis estimated that there were 4.95 million deaths associated with bacterial antimicrobial resistance in 2019, including 1.27 million deaths attributed to bacterial MR. So we can see this is the graph of different regions. According to different regions, we can see the South Asia is the most leading area where there are the maximum deaths associated due to antimicrobial resistance. This was the data published in 2019 in Lancet. So we fall in this South Asia region. India falls in the South Asia region. So we have the highest mortality due to antimicrobial resistance. Now, how we can, so we are discussing this antimicrobial resistance, but how we can tackle this problem? So this problem has to be tackled at different levels: at individual level, at professional level, at political level. So we will see how this has to be done. At individual level, we need to educate people to only use antibiotics when prescribed by certified health professionals. We need to educate people about using antibiotic, how to use it, how to store it, how to not use leftover antibiotic, and how to prepare food hygienically, choose food that has been produced without use of antibiotics for growth promotion or disease prevention, so that minimum use of antibiotic is to be done. We need to have a policy also. We need to have a robust national action plan to tackle antibiotic resistance. We need to improve our surveillance for antibiotic resistant infections, strengthen our policies, program, implementation of infection prevention and control measures, regulate and promote the appropriate use of disposal of quality medicines, and make information available on the impact of antibiotic resistance. As a healthcare industry, we need to invest more and more in research and development of new antibiotics and vaccines and diagnostics and other tools. In agriculture sector also, there is now a rapid increase in use of antibiotics in animals to improve the growth promotion and prevent diseases. But this is again causing more and more antimicrobial resistance. So we need to see that in agriculture sector, the antibiotics are not used for growth promotion or prevent diseases in healthy animals. We need to vaccinate animals. We need to use alternative methods other than using antibiotics and promote and apply good practices. As a healthcare professionals, we need to prevent and control the spread of antibiotic resistance. What we can do, we need to prevent infection by ensuring our hands, instruments, and environments are clean. Only prescribe and dispense antibiotics when they are needed according to current guidelines. Report antibiotic resistant infection to surveillance teams. Talk to your patient about how to take antibiotic correctly, antibiotic resistance and danger of misuse. Talk to your patient about preventing infections. For example, vaccination, hand washing, safer sex, covering nose and mouth when sneezing. So we need to minimize our use of antibiotics as far as possible for our future generations. Thank you. Thank you very much.
Thank you, Dr. Keyur, for presenting the topic so well in such a short duration of time. That was very important information. May I request Dr. Tanu Singhal to enlighten us further on this topic?
So I think that was a very nice ending to the entire presentation. So you can see that, lots of efforts are required by everybody. But now if I were to give a kind of a message to the audience and also a message for myself, is that, we need to implement whatever we have learned in these 4 or 5 presentations in our daily practice. So I think you have, kind of understood that you should use antibiotics only when required for bacterial infections. And we have also got guidelines about what antibiotics to use in various common infections in the community. We have learned about what to use in the NICU and what to use in the PICU. So I would encourage all of you to think back on these things. And from tomorrow, when you actually go back to your practice, try and see that how you can, incorporate whatever you have learned today in your practice tomorrow. Thank you.
Thank you, ma'am. Now I hand over to Dr. Sonali for further proceedings.
Thank you, madam. Any questions in the chat box? I think there are no questions. Dr. Ramakant sir, would you like to ask?
No, thank you. I'm mesmerized. And the most valid comment is the last one. It should not be just academic exercise. It has to be inculcated in daily practice.
Yes, yes, definitely. And from today's session, we had learned a lot about the antibiotic protocols as well as when to use the antibiotics and when not to use. And especially from the expert judges, we had learned a lot many points about the antibiotics protocols. So moving further to the end of the session now, by vote of thanks, I would like to thank our President MAHA-IP, Dr. Ramakant Patil sir, Secretary General, Dr. Amol Pawar sir, for the extreme guidance for this session. I would like to thank our guest of honor, Dr. Vasant Khalatkar sir, for his graceful presence for this session. I would like to thank Women's Committee Co-Chairperson, Dr. Neha Singh, and Convener, Dr. Manjusha Sherkar Madam, as well as all the zonal EB members, ladies, for the success of this session, because they has helped us a lot for this session in the very short time. I would like to thank our expert judges, Dr. Pramod Kulkarni sir and Dr. Tanu Singhal madam, for this session. They had given their valuable timings for this session, and they had said yes for this session, and in the very short period, they had just given their valuable time. Then I would like to thank all the 5 faculties of this session, because without them, this session was totally not possible, and they had prepared in a very short time, especially after Diwali. So I'm really very thankful to them. I'm thankful to our today's MMC observer, Dr. Rajendra Kulkarni sir. I'm thankful to our digital team, Dr. Pallavi Dharmadikari ma'am, because she always helps us a lot in every sessions. Thank you, madam. And I would like, last but not the least, I would like to thank all the audiences and delegates for this session, because without your presence, the session would have no meaning.